Hi, my name is Margaret Kress, and I'm going to talk to you today about my project, which was improving glycemic control in type 1 diabetic patients preoperatively. My committee was Dr. Amanda Flynn, which I'd like to give a special thanks to all of her encouragement and guidance through this program. Dr. Romi Chopra, who was the owner of the practice that I did my project at. Dr. Samir Ahmed, who is the medical director, and Dr. Shiva Tafazoli, a nurse practitioner that is a colleague of mine that is a recent graduate of Maryville University and encouraged me to go to this program. So diabetes, it affects 10.5% of the population, which is about 34.2 million people. Every year, about 1.5 million new cases of diabetes are reported, and it's an estimate that 88 million cases of pre-diabetes are diagnosed. By the year 2050, it's estimated that 1 in 3 adults will have diabetes in the United States. And diabetes is the 7th leading cause of death. A major risk factor for diabetes is peripheral arterial disease, PAD, which is defined as atherosclerosis in the lower extremity arteries. The treatment of PAD is a lower extremity angiogram with revascularization, and this restores the blood flow to the lower extremity, and if not treated in a timely manner, can lead to gangrene and even an amputation. So these procedures can be done in an outpatient surgical center, and it was found that patients were coming into an outpatient surgical center with hyperglycemia, requiring several hours of stabilization before the procedure. So this project took place at Mimit Health, which is in Melrose Park, Illinois, which is affiliated with Loyola University. It's a private interventional radiology practice that specializes in endovascular treatments and services. And we have what's called a limb salvage program that I developed and started about 3 years ago. The aim of this project is to improve glycemic control in type 1 diabetic patients preoperatively to prevent delays and cancellations of necessary surgical interventions, improve patient outcomes, and decrease healthcare cost. So this study is to determine if the implementation of an educational program for providers on type 1 diabetic glucose management improve glucose levels during the preoperative period as compared to pre-intervention glucose levels. So I did the review of literature, and all major databases were searched. I looked at articles related to type 1 diabetes and preoperative, perioperative, and postoperative phases. There were 3 main areas that I found: hyperglycemia, patient outcomes, and educational programs. So hyperglycemia in both diabetic and non-diabetic patients cause stress. The stress of surgery in these patients causes the blood glucose levels to increase, hyperglycemia. So stress hyperglycemia is defined as the elevation of blood glucose levels with an illness or injury and is associated with the increased risk of surgical site infections. Also seen was an increase in infection rates, prolonged wound healing, longer hospital stays, and postoperative mortality. Hospitalizations with poor glycemic control have been associated with an increased mortality rate of 50%. Studies reveal that well-managed glucose control in diabetic patients during the preoperative, perioperative, and postoperative stages improve surgical complications and patient morbidity and mortality. Patient outcomes. Over the past decade, there have been an increased awareness of diabetic patients with hyperglycemia in the preoperative, perioperative, and postoperative phases being associated with poor patient outcomes. Patients that present with very high perioperative blood glucose levels are at risk for are at high risk for complications postoperatively. Several observational studies were done in the United States and Europe, and they concluded that diabetes patients undergoing surgery had more comorbidities and risk factors than non-diabetic patients. So the length and severity of diabetes correlates with an increased risk of peripheral arterial disease, PAD. Chai and his associates did a study in 2020 that showed poorly controlled diabetic patients with an elevated hemoglobin A1C undergoing angioplasty for critical limb ischemia was associated with worse clinical outcomes, including amputation and adverse limb events. So, educational programs. Numerous studies support screening patients prior to surgical procedures to optimize glycemic control. There's an ongoing interest in the development of a systematic approach to improving glucose management perioperatively. Improvements are seen in clinical care of patients undergoing surgery with the implementation of a perioperative diabetes program. Guidelines have been available in the United States for a decade and have not been consistently used. So the development of a protocol detects perioperative hyperglycemia and can lead to a decrease in postoperative complications. So due to these issues, there's been an increased interest in to seek the best practice guidelines for managing diabetic patients undergoing surgery. So the theoretical framework that was used for this project is the framework for changing behavior model, and there's 7 approaches. So the 7 approaches include education, epidemiology, marketing, behavior, social influence, organization, and coercion. The approach that best fits this project is epidemiology, which assumes the presence of sound and convincing evidence and rigorous procedures, so the strategy must include strength and quality of the evidence. So of these changing behavior models, Rogers' innovation diffusion theory best fits this project. And Rogers' innovation diffusion theory explains how, why, and at what rate ideas are conceived by individuals. So Rogers describes how individuals proceed from having knowledge of an innovation to confirming the decision to adopt the idea. And there are 5 steps to this theory: knowledge, persuasion, decision, implementation, and confirmation. Each one of these steps have helped to incorporate my project into my practice. So this was a quantitative study looking at retrospective data. In this study, a protocol and order set was developed on correctly managing type 1 diabetic patients preoperatively. Education was given to the providers on the use of this protocol and order set, and EMRs were evaluated if an order was placed in the chart to adjust insulin preoperatively. There were 2 sets of data that were looked at, and one set was looked at before the education was given to the providers, and the second set was after the education was given to the providers. So this data was retrospective. And we were looking for a correlation between the education and if an order to adjust insulin preoperatively was placed in the EMR. And you can see right here on my slide of how the problem was identified. The EMRs were reviewed prior to education. Education was given to the providers. The EMRs were reviewed after the education, and then the protocol and order set was implemented. My sample size was 154 EMRs, and like I said, there were 2 sets of data that were analyzed. My inclusion criteria included patients that were 18 to 90 years of age, any ethnicity, any age, who were diagnosed with type 1 diabetes, and were having a lower extremity angiogram with revascularization in an outpatient surgical center between March 1st, 2021 and November 30th of 2021. The first 77 EMRs that met the inclusion criteria between March 1st of 2021 and June 30th of 2021 were analyzed and looking to see if an order was placed in the chart to adjust insulin before the education was given to the providers. The second set of data, which were 77 EMRs that met the inclusion criteria, and they were looked at between July 15th of 2021 and November 30th of 2021. And they also were analyzed to see if an order was placed in the chart to adjust insulin preoperatively. And this was after the education was given to the providers. So the exclusion criteria was anybody that was younger than age 18 or older than age 90, who did not have a diagnosis of type 1 diabetes and was not having a lower extremity angiogram with revascularization in an outpatient surgical center. So my data was analyzed in SPSS, and an upper tail Z test for the difference of 2 proportions was used to analyze the data. An independent sample t-test was used. This test compares the means of 2 independent groups to determine whether there was a statistical evidence that the associated population means were significantly different. The first independent variable was the group of EMRs analyzed before education was given to the providers, and the second independent variable was the group of EMRs analyzed after the education was given to the providers. So, results, and you can see here on my slide, a power test determined that the sample size of 154 patients was required. You can see here proportion 1, which was the EMRs after the education, was 0.97, and the proportion 2, which was the EMRs before the education, was 0. And you can see here that the charts reviewed before the education, 0 of them had an order placed in the chart to adjust insulin. And then the charts reviewed after the education, 75 out of 77 had an order placed in the chart to adjust the insulin preoperatively. A z-test statistic was 12.09, which determines if the 2 proportion means were different. My level of significance was 0.05, and the power of the study was 1. The power of a hypothesis test that is between 0 and 1, and if the power is close to 1, the hypothesis test is very good at detecting a false null hypothesis. So the null hypothesis was that there was not a correlation between the education to the providers on type 1 diabetes glucose management preoperatively and orders placed in the EMRs to adjust insulin preoperatively. So a confidence interval of 95% with an upper limit of 1.0 and the lower limit of 0.9. And I can conclude that there was a statistically significant difference in the two population values at the given level of confidence. So I can conclude that the null hypothesis is rejected. Limitations. There were a few limitations in this study. So the inclusion criteria may have caused selection bias, though each person was chosen such at a reasonable uniform process. The data was collected at 2 different intervals. So the providers in this practice had knowledge of the details of my project. So this may have triggered awareness that these patients' EMRs were going to be reviewed. So these providers may have done some self-education on correct glucose management of type 1 diabetes preoperatively prior to the education that was provided to them in this study. And then also, this study was done at a very small practice, which may have led to an unavoidable selection bias. The results cannot be generalized across other practices or hospitals, looking at several practices, which would have better provided us with a generalized sample. So, discussion. So diabetes affects millions of people throughout the United States and actually the world. Hyperglycemia in diabetic and non-diabetic patients preoperatively, intraoperatively, and postoperatively can lead to poor outcomes and increased healthcare costs. This study revealed that education to providers on correct glucose management of type 1 diabetic patients preoperatively improved the submission of orders to adjust insulin preoperatively in the EMRs by 97%. So the development and implementation of a protocol and order set can better manage type 1 diabetic patients preoperatively. Providers need to have current evidence-based education to manage these patients correctly. And this needs to be updated frequently to make sure that they're meeting the standards. This can improve patient outcomes, decrease delays and cancellations in these necessary surgical procedures, and decreased healthcare costs. So the implications for practice. This project can improve managing these type 1 diabetic patients preoperatively. It can help decrease healthcare costs, like I said previously. The education can contribute to competent and safe direct care to many patients. And these findings need to be distributed to colleagues, federal and state legislators, healthcare plans, consumer advocate groups, and healthcare consumers to improve care. And it also can lead interprofessional teams such as primary and chronic care providers, resource coordinators, patients, and family advocates to improve care. And it's all about knowledge. And I feel that with the patients that I see, families have lack of knowledge of even what diabetes is and what their risks are at. So to conclude, it was found that after education to the providers on type 1 diabetic glucose management preoperatively, patients were better managed at this practice. So providers were more aware of the impact that this had on the patients in the practice with better managing them preoperatively. The nurses were very happy after this was implemented because it decreased stabilization time, and they weren't stuck in an outpatient surgical center for 15 hours because of the delays and the cancellations. And of course, this can improve patient outcomes. This protocol also influenced better decision making of the providers in this practice. It influenced them to also develop policies and protocols about other diagnoses and improve care and have better knowledge about up-to-date care, quality care. So a multidimensional approach is essential to guarantee the improvements in knowledge transform to the accomplishment of glucose targets and improve patient outcomes. If there are any questions, please feel free to reach out to me. And I want to thank everybody for all of the encouragement and guidance in completing my project. It's been a pleasure to be a student at Maryville University. Thank you.